Hi everyone, I am Dr. Sagar Sahu and welcome to Vet Surgery at Ease. So today I welcome to another lecture in the series Radiology. Today we will be discussing the radiography pathology of the mediastinum. In the previous class we had discussed the diaphragm, okay, and also we have covering all these videos, especially the abdomen and thorax, radiography pathology of all organs of abdomen and thorax. I have made a total nearly 12 lectures. This is the 13th one. So if you want to watch the previous videos, I will give the link of the playlist in the description. Do check them out. Okay, let us come to our class. This is the radiographic pathology of the mediastinum. If you are following my lecture, you know which book I follow. That is the Veterinary Diagnostic Radiology by Tonali Thrall. Most of the pictures are from this book only. Okay, so if you want further studies, you can refer this book. Now coming to our main class. First of all, let us see some anatomy so that some concepts will be clear regarding the mediastinum. So here actually the right lung has been taken out so that you can see the mediastinum. Mediastinum has three parts. First one is the cranial mediastinum, which is basically cranial to the heart. The heart is itself the middle mediastinum, and beyond this, that is the caudal mediastinum. Okay, if you are going from cranial to caudal. If you want from dorsal to ventral, then at the heart base you can draw a line. This is dorsal mediastinum, this is ventral mediastinum. Okay, so let us see some structures actually in the from cranial to caudal. This is cranial, this mid, this is caudal mediastinum. Okay, mediastinum is the middle between the two lungs. So in case of cranial mediastinum, you will find many structures like this one is the brachiocephalic trunk, cranial vena cava. Here is the trachea going. Also there will be esophagus which will be going. Okay, so all these structures are present, but radiographically you can only see the trachea. This is the trachea, which is basically on the slightly right side, that will only be visible. In the mid section you will find heart, okay, the aorta and azygous vein. Just above this descending aorta, a greenish structure is here, that is the azygous vein, but it is not visible radiography. Radiographically you will only find the heart and the aorta. Okay, coming to the caudal mediastinum. In the caudal mediastinum you will mostly find the caudal vena cava. Here it is running the caudal vena cava. This is esophagus, this is the descending aorta, this one is the descending aorta. Remember the positions. Suppose any pathology will lie in this particular region. Suppose in this region there is a sternal lymph node also. Here you will find a sternal lymph node. We'll discuss that. So if you are finding this region, then you may suspect it might be some pathology of sternal lymph node, or if you are finding slightly caudal, then might be mediastinal cyst like structure. We'll see the radiograph also, just giving an idea that from that location you have to assess that you have to take a guess that which organs might have affected. Like if I will go craniodorsal, this is craniodorsal, so most of the time you will find the pathology associated with esophagus. Similarly, if you will go to caudodorsal, this region, most of the time you will find the pathology of this esophagus. Esophagus lies between the aorta and the caudal vena cava. Okay, this particular region is of esophagus. If you are finding some caudoventral, like here, this is caudoventral. In this particular region you may find pathology associated with long lobe, accessory long lobe. Accessory long lobe will be here. Okay, so this pathology may be happening. Okay, so these are basically the regions. Another thing you should know that the reflections. You see mediastinum, if you will divide at the heart base, this is dorsal mediastinum, this is ventral mediastinum. Heart lies in the mediastinum. So what happens if you will view from the top? Okay, so what happens, the dorsal mediastinum is kind of straight. Okay, it is kind of straight, but the ventral mediastinum, if you look at the ventral mediastinum, it is not exactly straight, it is like this. Okay, this one is the left side, this one is the right side, so that you can appreciate in the radiograph also. So it looks like this. This deviation is cranio-ventral reflection. Okay, and this deviation, okay, is known as caudo-ventral reflection. These are very important because in this cranio ventral reflection lies the thymus. If in young animal you are finding some pathology here, might be thymus gland, and this thymus gland lies in this cranioventral reflections. Like that, in the caudoventral reflection, mostly fat tissue will be there. If you are finding some lipoma in this particular region, then you may suspect that it is in the caudoventral reflection, and it is on the left side. Okay, it is on the left side. In radiography also we will see how you can tell that the mass is in the caudoventral reflection. Okay, so if I will superimpose this one here, then it will look like this. It will look like this. We will see in the radiograph also. So this reflection is cranioventral reflection, this is caudoventral reflection. Simply the ventral was slightly kinked or slightly bent. Okay, the cranial ventral one is slightly kinked towards right hand side, while the ventral one is slightly kinked towards the left hand side. But the dorsal one, this portion, this dorsal line is kind of straight, while this ventral mediastinum is slightly kinked. Okay, because in some radiographs you will see that there is slightly kinking. You might get confused, or you might get confused with some lesion or mass. Let us see some radiographs so that you can appreciate. This is a radiograph. Okay, can you see this deflection? See this deflection. Okay, this is cranioventral reflection. Cranioventral reflection. This is the mediastinum. You see, this is the mediastinum. This entire structure is the mediastinum, while this particular thing which is arising nearly from heart, this particular reflection is the ventral one, while this is the dorsal one. So this reflection is the cranioventral reflection. In this particular reflection lies the thymus gland. If at all thymus gland is visible, it will be like triangular structure in this reflection. In this particular reflection you will find this thymus gland. Okay, similarly in the caudal side you can see a line. Can you see a line? This line joining up to the diaphragm, this particular line. This is basically caudoventral reflection. Many a times it is confused with the phreno-pericardial ligament, but it is not that structure. It is simply the reflection, caudoventral reflection. It means the ventral one is slightly kinked. Okay, this particular structure. So this is basically some anatomical consideration regarding the mediastinum. And sometimes you see, let me show you this one. You see, as this one is kinked, okay, kinked, and here is the left lung. This is left lung, this is left hand side, this is right hand side. Okay, this is kinked. It means here is the left lung and here is the right lung. Sometimes it is not visible in lateral radiograph, but in some cases, especially in the left lateral radiograph, you may find this reflection. Can you see this band like structure? Okay, this structure is the left lung, this one is the right lung. It is kinked towards the right side. Okay, this one is the right lung, and this particular band is basically the deflection. Okay, the cranioventral reflection, because it is reflected in the radiograph, that is a cranioventral reflection. Okay, cranioventral reflection. It is visible in left lateral. Okay, it is not visible in right lateral. So this is basically anatomical things. Regarding the diseases of the mediastinum, it is basically, you can classify the disease into three things. First one is the mediastinal shift. Second one is the mediastinal masses. Okay, I told you regarding different regions. Okay, so here we will see the region wise masses. Next, third one is the pneumomediastinum. One thing I actually left, or it slipped my mind, let me show you. Pneumomediastinum is third one. We will discuss all. Another region is hilar. I told you this is cranioventral, craniodorsal, caudo-dorsal, Here trachea will come. Trachea is on the right side, that is not visible, and it will end at carina where the trachea will bifurcate. This particular region is known as hilar region. Hilar region, because the hilum of the lungs will be present here. So hilar region, this is also a region. There are some pathologies associated with the hilar region also. Okay, let us go to our mediastinal shift. So regarding the mediastinal shift, so mediastinal shift has some, when you will say that mediastinum has shifted, the most reliable indicator is the heart. When the heart will be shifted, whether to left or right, then you can tell that the mediastinum has been shifted. First thing. Second thing is that when it will get shifted, the most common cause is atelectasis. Atelectasis. It may be due to chronic pulmonary disease, or it may be chronic recumbency. When there will be chronic recumbency, also the lungs, the dependent one to which the animal has been recumbent, will get atelectic, and you will see the mediastinal shift. You will see some radiographs also. Let us see some radiographs. This is a radiograph. You can see that the heart has been shifted to right hand side. This is right, this one is the left. You can see that mostly the heart will be lying in the center, slightly towards left is the normal position of the heart, but in this particular case it has been shifted to right hand side. It means there is some problem with right hand side. If you will clearly see, notice this particular opacity, okay. Rest of the lungs has some opacity, but this opacity has been changed. Most probably this lungs has been collapsed. You need multiple views to diagnose this, but in this particular case, when the radiograph was taken, this particular long lobe, this one will be the right middle long lobe, right cranial, right caudal, right middle. Here will be the accessory long lobe, which is of right lung, and here you will find the cranial long lobe and caudal long lobe of the left one. Cranial is divided into craniocranial, craniocaudal. Okay, so this is basically the collapse of right middle long lobe, which has resulted shifting of the heart towards the right. It means the mediastinum has been shifted to right side. Okay, let us see another radiograph. In this particular case, the animal was recumbent, old animal, recumbent for 12 days. After that, the radiograph was taken. You can see that the heart has been completely shifted to, majority has been shifted to left hand side, and also the lung is not that kind of visible result because of atelectasis of dependent lobe, because the animal was on left lateral recumbency for 12 days. Okay, so this is basically mediastinum shift. Next is the mediastinal masses. Will go region by region. First one is the cranioventral. I told you about the sternal lymph node. Most common pathology lies in the cranioventral thing is sternal pathology, the sternal lymph node. The sternal lymph node you will find in the sternave 2 and sternave 3. In this particular region you will find the sternal lymph node. Okay, it will be having a very wide base. You can see the base is very wide. Okay, this is the lymph node. Normally the lymph node is not visible. If at all visible, it will not be more than 3 cm. Okay, if it is beyond this, then the lymph node has been swollen or some pathology lies with this lymph node. Interestingly, if the sternal lymph node has been swelled or has been there is the enlargement of this lymph node, it does not mean that the pathology lies with the thorax. It means that the pathology lies with the abdomen. Okay, abdomen, mostly the peritoneal metastasis. The pathology lies with the abdomen. And one more thing, you can see that this is actually right lateral view, this is left lateral view. You can see that this here it looks like this, while in this particular radiograph it looks like this. Okay, it may change its shape depending on the radiographic beam, how it hits this particular lymph node. Okay, so it may change shape in different views, especially the lateral view, so you don't need to worry, it is simply enlarged. This is sternal lymph node. Let us see some ventrodorsal and other things. Here the sternal lymph node is slightly more swollen up. Okay, the cranial border is not that visible. This is S1, this is S2, S3. In this particular region you can see there is swelling, and if you will go see if there is swelling in the lateral radiograph, it might be in mediastinum or it might be in lungs. So you have to take a VD view to confirm. In the VD view it has been confirmed that, can you see the mass? This is the mass. Okay, so this is in the mediastinum rather than in lungs. So you can tell that it might be sternal lymph node based on the region. Next structure is the mediastinal cyst. The mediastinal cyst is very common in case of cat rather than dog. It is more common in cat. The mediastinal cyst will always occur more caudal to sternal lymph node. Okay, near to heart. This is the cranial border of the heart. It will be more close to the heart. This is the cyst. I told you that it might be long lesion or it might be in mediastinum. So you have to take a dorsoventral or ventrodorsal view. In ventrodorsal view you can see there is a swelling. Okay, though the margin is not that clear, but in this particular region you can see just cranial to the heart there is a swelling. So in this particular cat, this is the mediastinal cyst. The cystic nature should be confirmed by sonography. Okay, because the radiography won't tell you that whether it contains anything. It will simply tell you it's a mass. So you have to ascertain the nature of the mass from sonography. Okay, let us see the same cat after 1 year. The cyst was not drained, so you can see how big it has been. This particular case, see this cyst, and in the radiograph you can see how it has been enlarged just cranial to the heart. So mediastinum has been slightly widened, or you can say enlarged. So this is in the mediastinum rather than in lungs. So this is mediastinal cyst. It is more common in cats. Next is the thymus. You see thymus usually regresses within 1 year. Okay, within 1 year of age. Within 1 year of age. So many a times it may persist for longer period of time, and it may have some lesions. Mostly the thymus lesion will be a tumor, that is thymoma. So thymoma, it should always be confirmed by fine needle aspiration biopsy. Okay, it is not the radiography which can give you a data regarding the nature of the tumor, especially the thymus gland. It can only tell you that it's a mass. Then you have to go for FNAB, fine needle aspiration biopsy. Then you have to confirm whether it is the thymus, or even sometimes the sternal lymph node is very big. It is very difficult to tell whether it is a sternal lymph node or not. From location you can take a best guess, but you have to go for the fine needle aspiration biopsy to confirm that structure. So in this particular case you can see here is the mass. Okay, the entire cranioventral surface or cranioventral region has been, radio opacity has been increased. Okay, so here you can see, from I told you it can be confused with long things or long lesions. Here you can see that the mediastinum widening. Mediastinum has been widened. Okay, so it might be some mass in the mediastinum. After FNAB, it was confirmed that this was thymoma. Okay. Next is large mass, any kind of mass, whether it is lipoma or anything. Most commonly mediastinum contains fat, so you will find mostly the lipomas. So here what happens when the mass gets bigger, even if thymoma when gets bigger or any swelling gets bigger, much bigger, then there will be dorsal deviation of the trachea. Trachea will be dorsal deviation. You can see that it nearly parallel to the vertebrae column. Okay, it should have some angle, but instead it has become parallel. And also you can see that cranial border of heart is not that visible. There is a border replacement with the structure. This one is the tumor structure or a mass structure which has the cranial border replacement with the cranial border of heart. In BD view also you can see that mediastinum is highly widened. Okay, this one mediastinum highly widened, and also it has border replacement with the heart, cranial border of the heart, border replacement. That means you cannot distinguish the border between the mass and the heart. Another radiograph of a large mass. This is also a large mass. Okay, here the heart is not that much visible. Okay, though you can tell something here. but it is not that visible because you can see this mass, irregular mass actually some. So this is basically the entire cranioventral thorax has been opacified and the trachea has been pushed further. Okay, and from the views you can see that it is in the mediastinum. This is the lungs. Okay, here it is lungs, it is in the mediastinum. Can you see the trachea here? The trachea is slightly towards the right hand side, so slightly bent also, but it's okay. So here you can see that the ventral border of heart is visible, but the cranial border of heart is not visible. It is has some border replacement with the legion. So basically this is cranio-ventral thing. Next, cranio-dorsal. I told you when it is cranio-dorsal, mostly it will be the esophagus. Legion might be lying in the esophagus. Mostly you will find megaesophagus, or you may find vascular ring anomaly. Megaesophagus due to vascular ring anomaly. Persistent right aortic arch or aberrant subclavian artery. Okay, those things. Here it is only visible because esophagus contains gas here, so they can see that esophagus has been dilated. Okay, that might be some fluid opacity in this particular region, and the trachea has been ventrally deviated. Okay, so you have to go for esophagram for further diagnosis. Esophagram, where you have to give barium sulfate, nothing else. Okay, so in this picture you can see that the mediastinum has been widened. Here are the lungs, here and here is lungs. So lungs is fine, it is in the mediastinum. Next, this is an incidental finding, a case report. Okay, the radiograph in which there is increase in opacity in the craniodorsal thorax. In the VD view you can see that it is in the mediastinum. Okay, it is in the mediastinum. Lungs are fine. So it was a case of actually abscess. After fine needle aspiration from that particular region, it was found to be abscess. Okay, just remember the regions and the organs there, then diagnosis will be easy. At least your probable diagnosis will be good. Next, the caudodorsal. This is caudodorsal region. This region is the caudodorsal region. I told you between the abdominal aorta and the caudal vena cava lies the esophagus. Okay, this is part of descending aorta. I told you abdominal aorta, sorry, not abdominal, descending aorta. This is caudal vena cava. Between this region lies the esophagus. Okay, if this soft tissue opacity has been in this region, in this region, then you have to suspect for hiatal hernia. Okay, I have discussed hiatal hernia in the previous class also, in the stomach class also. Okay, but here is generalized opacity has been increased, so it might be esophageal foreign body, or sometimes the spirocercal loopy, which causes the tumor of esophagus. So we have to confirm it by esophagram. So you can see here something is here. Can you see this line here? This is the cranioventral reflection I told you about. Okay, this is cranioventral reflection, not phrenopericadial ligament. Okay, so coming to our thing, you can see that there has been some mass here. Okay, soft tissue opacity, but it should be confirmed by esophagram. Barium sulfate you have to give. Caudo-ventral, I told you two structures, the accessory long lobe or the any fat, tumor of any fat. So here you can see a mass is here. It has border effacement with the caudal border of, this is caudal border of heart, border effacement is there. And I told you, but remember, it may be diaphragmatic hernia, but here you can see that diaphragm is clearly visible. Okay, so it is not a case of diaphragmatic hernia. So it might be something, but the thing else, accessory long lobe lies exactly at the midline. So you can see that the mass here is exactly at the midline. Okay, exactly at the midline. If let's see, if it has been a reflection mass in the caudo-ventral reflection. Okay, reflection is towards left hand side. Here is the mass, but remember the thing, here is the mass. It is in the left side rather than in the middle. This is the differentiation between the mass in the reflection and the accessory long lobe. Okay, here the heart is also pushed towards the right hand side, that is the mediastinum shift to right hand side. Okay, this is the basic difference between the accessory long lobe mass. Another difference is it is not that a prominent sign, but whenever there will be mass of accessory long lobe, it will have border effacement with, here you can see the cranial caudal vena cava, the ventral border is not that much visible. Okay, so when there will be accessory long lobe mass, it will have border effacement with the caudal vena cava, because caudal vena cava actually runs through the accessory long lobe. So you may not find the caudal vena cava in case of accessory long lobe mass, but only if the mass is big enough. If it is small mass, you may not find the border effacement with the caudal vena cava. Okay, so it is not a reliable sign, but you should know this. Now the hilar region mass I told you about. The hilar region, when the trachea bifurcates, are the region of carina. These are the region of carina. You can see a mass here, soft tissue opacity are the region of here, and the carina has been cranioventrally flattened, bent. You see, it should be like this. Instead, it is like this. Okay, cranioventrally bent. Okay, here you can see it's a better view. You can see the carina, it is cranioventrally bent, and you can see a mass here, soft tissue opacity here. There can be two things. First one is tracheobronchial lymph node, I have written here tracheobronchial lymph node, or it can be mass of heart base. The basic difference between these two is, in tracheobronchial lymph node, the mass will have a distinct border. We'll see some radiographs also. But in case of mass of heart base, the border, especially in dorsoventral or ventrodorsal view, especially in mass heart base, the mass will be ill defined. Okay, it is not that much defined. Even it gets bigger, we'll see some bigger heart base tumors where the mass is not clearly visible. Okay, so another thing is the splaying of the bronchus, primary bronchi. We'll see. Okay, so here is one mass and here is one mass. Let us see. This is tracheobronchial lymph node. Tracheobronchial lymph node is three in number: the left, the center or the middle, and the right one. Well, the important one is the right center one. Left and right are very small. The important one is the center one. Okay, let us show you. So what happens? This tracheobronchial lymph node lies exactly between the bifurcation here. Exactly here. Okay, so when it is mildly swollen, it may not produce any pathology of the bronchus, but when it is severely swollen, there is this splaying of bronchus. This is splaying of bronchus. Let's see here, you can appreciate here that this is the soft tissue opacity here. Okay, this is heart, and here is slightly soft tissue. If you look at the bronchus, this is trachea, you can see the bronchus, it is like this. This is like this. This is splaying of the bronchus. Okay, this is characteristic of tracheobronchial lymph node. This exact sign will be also produced radiographically by left atrial dilation. Okay, but the signs and symptoms will be different. Okay, by that, and also the lab test will be different. And for heart, we can go for echocardiography for the further diagnosis. So you need further diagnosis. Okay, so this exact differential diagnosis is left atrial dilation. Okay, so this is basically the radiography pathology when the tracheobronchial lymph node is involved. Next is the heart base. Here you saw that how clearly the mass is visible. Okay, but if a heart base tumor, you can see here clearly the trachea is slightly pushed upward, there is also the cranioventral bending. You can see that, clearly see that the heart base is might be swollen, but you cannot actually identify or define the border of this mass. Even in the VD view, you can see the heart. This is heart, here is the heart, but you cannot see where this tumor is, this ill-defined tumor or ill-defined mass. It can be a tumor or other things. So this mass is ill-defined. It is characteristics of heart base enlargement or heart base mass. Okay, can you see the deflection here? Okay, this is cranioventral deflection or reflection. Next, this is a very severe case of heart base tumor. You can see that the mass is not defined. You can see some borders of heart here, but the mass itself is not clearly defined. The trachea has been pushed upwards, and there is also cranioventral bending of the carina. Okay, the tracheal bifurcation, but still the mass is not that visible. So how to diagnose? Is there any radiographic sign? Yes, of course. In this particular case, you will find that the bending of trachea just cranial to the bifurcation. So you see, here is the bifurcation. This is the bifurcation. You can see. Okay. So just cranial to the bifurcation, trachea will be bent. The trachea has been bent. Okay. This is a characteristic of a heart-based tumor. When it is further enlarged, there will be further bending. Let me show you here. Okay, here is the tracheal bifurcation. This is trachea. You can see that it is further bent towards right. Okay, this is a characteristic sign for heart base masses. Okay, so this is basically the heart base masses. Hilar region, we have covered all these regions. Next, how to differentiate between the mediastinal mass and the pulmonary mass? I told you first is comparing the DV and VD view, but one of the thing is that pulmonary mass will have a very distinct border due to the lungs, which will be providing a contrast, but it is not always true. For example, this particular radiograph, you can see that some mass is in the cranioventral region because the opacity of this cranioventral thorax is of soft tissue opacity. So when it was viewed on the dorsoventral or ventrodorsal view, you can see that due to presence of lungs, you can see that it is clearly defined that there is some mass here. So you may tell that it might be pulmonary mass. But when a CT image was taken, you can see that this mass is actually in the mediastinum, not in the lungs. So it is kind of difficult. The confirmatory diagnosis should be CT for specially for the mediastinal masses. But if you do not have a CT, you have to somewhat rely on the radiograph. Next, this is also similar case. You can see a mass here, might be nodule of lungs. When you will go for the ventrodorsal view, you can see a nodule. Most of the time you will tell that this is a nodule. You may diagnose it as a metastatic nodule or anything. Okay, but when the CT was taken, it is simply an extension of a mediastinum. Okay, so there might be some confusion regarding the how to properly diagnose the mediastinal mass and pulmonary mass from radiograph. Okay, the CT is the ultimate confirmatory tool. Okay, next, effect of peritoneal fluid. Sorry, pleural fluid. I'm sorry, pleural fluid. What happens due to presence of pleural fluid? Everything gets disturbed. Okay, so entire ventral thorax is of soft tissue opacity when there is sufficient amount of fluid. Okay, so what happens? It masks almost all type of lesion in the thorax. So you have to remove the pleural fluid. Then after you have go for another radiography. Means this particular thing, you can see that the lungs is kind of floating. Okay, sorry, here this lungs is kind of floating. And one more thing, you see this lungs margin, it is kind of smooth and circular type. Okay, it is an indicator for pleural fibrosis. In the next class we will discuss the pleura. There I will tell you regarding this very vividly, how pleural fluid works, how to take different views like that. But in this particular, for your knowledge, I am telling you that this is of pleural fibrosis lungs has been collapsed due to accumulation of the fluid in this ventral portion. Okay, so this mask, even the heart is not visible, anything is not visible here. Okay, so this may mask some mediastinal lesions, so you have to take out the pleural fluid, excess pleural fluid, then you have to do the radiograph again. Okay, next is the pneumomediastinum, the last disease of mediastinum. So pneumomediastinum, pneumo means air in the mediastinum. When there is sufficient amount of air present in mediastinum, all those structures I told you, brachiocephalic trunk, the cranial vena cava, the azygous vein, these are not visible radiography. So when the mediastinum has air, it will provide contrast and these structures will be visible. That is the confirmatory diagnosis for the pneumomediastinum. Here you can see that this is descending aorta, here descending aorta. Can you see a very thin structure here? Here this one. Okay, this is the azygous vein. This is the azygous vein. This is caudal vena cava. You can see the cranial vena cava also. Okay, and another important one is you can see the adventitial surface of the trachea. Trachea has two surfaces. The outer one is the tunic adventitia, and the inner one is the mucosal layer. So when the thing will have a soft tissue opacity, only the trachea will be visible, and that too only the mucosal surface will be visible. But when there will be presence of air, the adventitial surface will be visible. It is more of characteristics or diagnostic or pathognomonic lesion for pneumomediastinum. Okay, when it is pronounced, if it is in small amount, here you can see some close-up view. Okay, this is cranial vena cava, this is brachiocephalic trunk, and you can see the trachea. The trachea is having both the mucosal surface and the adventitial surface is visible. Okay, even if the esophagus is slightly visible, which is running on the side. Next, the pneumomediastinum, when the minimal is thing, mostly you will find why the pneumomediastinum happens, because you see it may leak from because pneumomediastinum has fenestrations. Okay, so through that fenestration, the lungs, air leaking from the lungs or any pathology, it may get into the mediastinum. So in case of minimal, you will find only the mucosal and the adventitial surface of the trachea. Here is also, you can also find some air pockets in the mediastinum. It should be confirmed in the VD view also. Okay, so these are some minimal pneumomediastinum. One thing is that when pneumomediastinum and subcutaneous emphysema coexist, this subcutaneous emphysema provides contrast to mediastinum also. So sometimes they are misdiagnosed as pneumomediastinum when there is severe emphysema. In this particular case, you can see that it is severe emphysema. This is severe emphysema. So it may result in either in wrong diagnosis of pneumomediastinum, or it may overestimate the gas present in the mediastinum. So we have to be slightly careful. Here also you can see that cranial vena cava, the adventitial surface, the mucosal surface of trachea, descending aorta. Okay, and there is some vessel running here. Okay, all those things you can be, it is very clearly visible, which should not be visible in normal radiograph or survey radiograph. So this is all about the mediastinum. Last one. This is not actually disease but a complication actually. So what happens? This mediastinum connects with the retroperitoneum in abdomen and also the neck. So sometimes when there is air built up in the mediastinum, it can get leaked into the retroperitoneum, causing the pneumoretroperitoneum. Okay, this is pneumoretroperitoneum. Here is the border of kidney. So in this particular case, you can see that here the air is present in retroperitoneal space. Here is kidney. Okay, air is present retro. So it's very rare case, but it may be found. Okay, so this is all about the pneumomediastinum and regarding radiographic pathology of mediastinum. Next we will go for the radiographic pathology of pleura. Mostly we will deal with the pleural effusion and the tension, pneumothorax, all those things. Okay, so till then, tata, bye bye, take care.